Good, good afternoon, dear colleagues. We will continue our webinars concerning on drug safety, and today we will talk about drug safety in elderly patients. This topic is very actual because elderly patient is category sensitive category of patient which need special conditions for administration of drugs, and you should take it into account. Not just age, but and physiological condition of patients, elderly patient. It is age-specific problems of elderly patient. Elderly patients are characterized by such as multi-organ functional decline, alteration in mental status, depression, reduced nutritional status, and the absence of social support. The biological age of this patient is one of the most important parameters and should be defined individually based on comorbidities and status performance. For our new participants of our webinars, let me introduce myself. My name is Galina Cardera. I am qualified person of pharmacovigilance with more than 10 years experience as a QPPV and head of pharmacovigilance department and clinical expert plus. I am a medical doctor. I with scientific background, physician, and with experience with patterns and writing articles and some books. Why it's important again? Because the typical frail elderly patient has that we saying that we should provide a complex approach for patients, taking into account comorbidity, drugs which this patient taken in this time, because we understand this elderly patient has many can have many diagnoses, many diseases, and it's important. For example, if we talking about portrait of elderly patient, it can be problems as problems with joint, problems with vessels, vein and arterial ischemic disease of heart. Can be problem with arrhythmia, problems with heart plus it can be kidneys problems, it can be disease of diabetes mellitus. Majority of patients can have, and we know about it. What this means? That this patient, elderly patient, has multiple diagnoses, taking several different medication, reduced renal function. It's because of age. It's specific or concerning on age, increasing body fat levels and reducing homeostasis with decreases immune system. Plus, when we're talking about elderly patient, it's concerning on metabolic landscape and cardiac aging. We see that like a magic circle. I say like this because we see that problems of metabolism can be illustrated in tissues, in pathologies. Then plus it can be involved with pathophysiology specific. It's why specific category is elderly. What we see in this circle, it means this substrate metabolism has specific cellular and molecular network, and dysfunction mitochondria. And what about mitochondria specific condition is tissue hypoxia. Insulin resistance can be involved in this process, cellular interaction, epigenetic modification, dynamic and metaphagy, and oxidation, phosphorylation. It means oxidative stress can be increased in this category of patient, and lipid storage. What this mean in pathophysiology level? It means there can be dysfunction in ATF production, systolic phenotype, signal transduction, electron transport, inflammation. Inflammation, reason of it is oxidative stress. And inflammation, we see this, for example, nature of diabetes, it's inflammation, non-infection inflammation, cell loss, DNA damage. And when we are talking about process, we see that increased in this category patient, elderly patient, is inflammation, oxidative stress, cell loss, DNA damage, and decreases its ATF production, systolic phenotype, signal transduction, and electron transport. What kind of process taking place in tissues? It's vascular remodeling, and this process lay down in natures of arterial hypertension, remodeling of myocardium, taking into account 2 plus. We know that molecules is become L-selectin and pro-inflammatory interleukins playing a role in process like inflammation, and plus it's vascular remodeling, and you can find in ultrasounds investigation why this category of patients should be carry out such diagnostic procedure like ultrasound investigation. In heart, it will be a process of hypertrophy, and its majority cases, its left ventricular can be hypertrophy. It's why this category of patient has arterial hypertension. It can be nature of like central hypertension, plus it can be hypertension because of pathology of kidney too. When we're talking about aging process in heart, it's myocyte growth, myocyte systolic dysfunction, lipotoxicity, cell proliferation, fibrosis, and aging heart. Why we stop it and precisely paying attention to this process? Because knowing pathophysiology and knowing what kind of process taking place in pathophysiology, we can understand what's going on in tissues. If we can understand targets for treatment, plus we use a complex approach for patient, for every category of patient. It means that we understand what's going on in this patient and organism in this patient, and we understand that this patient again has comorbidity because of age. And we see that this process, when we talked about previous slide, its arrest proliferation can be, it's hemokines, it's cytokinase, hemokinase, and we see this it's mean pro-inflammatory cytokinase in interleukin 1 beta, interleukin 6 tumor necrotic factors, and interleukin 8. It's proteases and growth factors like tumor growth factors B, and we see that it can be this process laid down as a base of pathology, and why we're talking that elderly patient has different multiply diagnosis because of complex of pathological process. And we see that it can be heart failure and atherosclerosis. It's chronic obstructive pulmonary disease which increase a typical pathological process as tissue hypoxia. It's Parkinson's disease, Alzheimer's disease. It's age-related macular degenerations, problems with eyes, and we know it that elderly patient has this problem. It's presbycusis and benign prostatic hyperplasia when we're talking about category of men, elderly men patients. It's problems with joints. It's because of degenerative process in joints. We see osteoarthritis, osteoarthrosis, and parallel. Don't forget about the drugs which can be a reason of falls down for of patient of this category, because osteoporosis can be reason on fracture of bones. It's very important too, and please pay attention on this point in your practical activity. Type 2 diabetes mellitus is a process. Is a majority of elderly patients have type 2 diabetes mellitus and should have complex of problems, because you know that first of all, type 2 diabetes, it's inflammation process, and it's can be damage of vessels, endothelial dysfunction. Why is effective drugs with has target anosynthetize, beta adrenal blocker, nebivolol as drugs, and we will talk about this group of elderly patient too. And it's problems with liver, it's non alcohol damage of liver problems, and because of age, plus it can be reason of disorder of nutrition. And we see that one patient can have several diseases. It means that this patient can take treatments of every disease what we see on this slide. It's why we use complex approach for every patient, taking into account their comorbidity. And again, when we're talking in this molecular process, you see that it's all connected. Its problems with synthesis of lipids and acetyl coenzyme A, fatty acid, triglyceride, fatty acid uptake, increasing during ages and decreases ages. It's mitochondrial dysfunction which lead down in nature diabetes mellitus, ischemic heart damage, stroke of heart, stroke of vessels of brain. It's you should understand. It's why when we talking about groups of drugs like coenzyme A, and like drugs as ubiquinone from plant, and for example catalysator of Krebs. The groups of drugs can be effective because of mitochondrial dysfunction. And because of point is normalization of process on cell level. Plus aging-related diseases you see that connected with lipotoxicity, energy depletion, altered cell signaling, and you see that, for example, when you compare young adipose tissue and of elderly adipose tissue, you see that it can be metabolic disorder because of leptin, adipokinin. It's two categories of signaling molecules which play a role in obesity, and why obesity still is a non-infection inflammation too, as when we're talking about pathophysiology of this process. Plus its aging problems can be parallel its adipocyte enlargements, senescent adipocyte, and macrophage infiltration too. When we're talking about age-related changes in physiology and function, we will make in focus every system. We will start from body system, cardiovascular, changes in cardiac muscle fibers and electrolytes. All the persons are more prone of arrhythmias. You remember it when you administrate tricyclic antidepressants as a group, or another group psychiatric and drugs, and because one of adverse events can be arrhythmias, and every physical therapist should check the pulse before administration of drug and to determine any change in cardiac rhythm. Plus, it can be declining in cardiovascular system response to stress. In order to diminish stress of the cardiac muscle, warm up and cool down periods are necessary. Increasing systolic blood pressure, check vitals before, during, and after activity. Significant changes should be documented. You may need to refer the patient back to the primary care physicians before continuing with the exercise program. Increasing in peripheral resistance can be in elderly patients, and when we're talking about age-related changes in cardiovascular body system. This change will be noticed in the increased efforts on the left ventricle, which will show in the blood pressure by the end. Decreased minimum heart rate. Conventional heart rate formulas used for the young may need modification for older person. Those formulas will demonstrate the target zone heart rate that will be allowed for exercise routine. Decreased diastolic filling rate. Frequent rest may be needed with longer bouts of exercise. Check pulse and respiratory rate in order to adjust exercise intensity. Decreased ventricle compliance. Monitor heart rate and blood pressure during exercise and high level. You should take into account too when you're talking about age-related change in cardiovascular system. Decrease in ventricle compliance. You should monitor heart rate and blood pressure during exercise in higher levels. When we're talking about pulmonary body system as age-related changes in physiology and function, decrease in change wall compliance and decrease in lung elastic recoil, you should as a therapeutic consideration with age. Chest mobility is important to allow sufficient amount of air exchange. Therefore, they need sufficient oxygen during exercise. Therapy should monitor respiratory rate and pattern. Increasing calcification on the ribs. Special consideration for mobilization techniques should be considered. Also be aware of osteoporosis and the potential risk for fracture. Decreased intercostal muscle strength, diaphragm strength, abdominal muscle strength, and other ventilatory muscle strength. The older population may present with diminishing endurance, which will cause them to easily fatigue. Changes in spinal curvature that will be diminishing breathing capacity. Decreased maximum voluntary ventilation. Slowly progress exercise programs are gradually returned to baseline 20 years of age. Residual volumes increased. There's more unused air in the lungs, and lungs cilia less and less strong. Person may be more prone to pulmonary dysfunction and infection. Be aware of environmental changes. Gastrointestinal age-related changes. Decrease in motility of esophagus after eating, a sense of substernal fullness is felt. Lower esophageal resting pressure and hesitance of sphincter, more reflux and heartburn. Decreased motility in the stomach, intestines, increased evidence of constipation, encourage activity and hydration to combat this. Decreased blood supply to the gut, increased incidence of constipation, but can become more serious and cause fecal impaction. Renal, decreased mass and weight, less effective. Protein binding of medication is decreased. Prolonged drug effects in older person because of, we remember, decreasing renal function as well. Hepatic changes with age, liver mass and blood perfusion decline, metabolism of many drugs is decreased, decreased vascularity, less productive, decline in excretory and reabsorptive capacity, prolonged drug effects, decreased urine concentrated ability, urine will be less concentrated. Urinary change with age include increase in residual urine. It can be as a therapeutic consideration, difficulty completely emptying the bladder and more urinary accidents, and increased reflux in the ureters, more symptomatic and asymptomatic bacteria. Cartilage, it's important when we're talking about cartilage, muscle, skeletal dysfunction and changing with age. You should take into account changes with age. When you talk cartilage deteriorates, person will need more strength around the joints. Decreased hydration, shock absorbing ability and less, so as a way to attenuate the force will be needed. Reduced elasticity, joint motion may take longer to stretch and need additional modalities and mobilization for increasing motions. Increasing fibrous growth, joint may appear larger than when young. Muscle has atrophy in number of fibers, especially type 2 fibers, and it can be progressive. Resistive therapeutic exercise should be aimed and specifically identified the type of weakness and appropriate exercise. Decline in alpha motor, quicker gains in strength may be seen in older comparing younger person because of atrophic influences. Decreased maximal strength north of for increase in age in all muscles group will be less than for young. Decrease in muscle mass. Girth measurements are not reliable measures of improved strength. Skeletal body system has changed with age and it reflected as decreased calcium. Calcium supplements or medication must be taken in conjunction with exercise for significant result to occur. Decreased circulated levels of vitamin D. Person must also get a minimum of 10 minutes of sun exposure 3 times per week. Because of decreased circulated levels of vitamin D, or take a vitamin D supplement to get the benefits of increased bone strength. It's why you see that it can be a pathological process be laid down as in nature of fracture, osteoporosis, because of decreased calcium, circulated levels of vitamin D, plus decreasing bone strength as well, and weight-bearing muscle contraction, progressive resistant exercise have been shown to improve bone strength in this way. Also, persons with weaker bones are more prone to fracture, so care should be taken and exercise programming, and persons should be screening for risk of falling as well too. Decreased reserve to quickly accelerate the production of red blood cell. Patient may become anemic more easily when stressed and may take longer to respond to medical management. Central nervous system included decreased brain mass, significant losses occur in cerebral cortex and cerebrum, affecting cognition and balance. Decline number efficiency of neurons, longer conduction time coupled with fewer neurons leads to slower responses, increasing energy expenditure during activity. A slower conduction velocity, sluggish positive writing response and prolonged inefficient muscle contraction. Decrease in neurotransmitters, including sarcopenia, this slowing the neuromuscular junction, leading to atrophy and inefficient muscle function. Intersystem homeostasis, including hypothalamic thermostat declines. Older person may need more time to accommodate for stabilized body temperature, whether due to changes in activity or the ambient temperature. Basal metabolic rate decreases, body weight increases, and weight gain is easy. Reactivity of the autonomic nervous system declines. Skin hydration and circulation may be slow to respond when necessary. Vasomotor system less responsive to warming and cooling. Older persons are more prone to hypo and hyperthermia. Decreased hormonal balance, exercise tolerance will be affected. Older person will be slower to reach homeostasis during exercise, and the return to homeostatic state following exercise is prolonged. Decreased blood flow to the brain. Blood is adequate for daily activities but may be insufficient when exercising. Monitor signs for decreasing blood flow when exercising. Decreasing nerve cells, slower reaction time. When we're talking about peripheral nervous system and decreasing blood flow to nerves, increasing activity improves blood flow to the nerves. Sensory touch. Receptors and nerve fibers decline with age, and care should be taken when using hot or cold modalities, as older person may have decreasing sensitivity. Skin changes such as dermal thinning, decreased elasticity, and vascularity. Older person may bruise easily, repair skin injuries more slowly, and be at increased risk for adverse effects of sun exposure. The number and size of sweat glands diminish. Older persons may not have an adequate sweat response, so they should be checked for signs of hyperthermia when exercising. When we're talking about vision, decreasing in muscle tone, less responsive to eye movements, loss of elasticity and orbital fat around the eye that may affect self-esteem, diminish tear production, encourage the use of artificial tears if dryness is noted to avoid ocular inflammation or infections. Ocular pupil is smaller, the ability to focus far to near declines, as thus adapting quickly to light and dark. Tendency toward increasing intraocular pressure, more prone to glaucoma. Older persons should get their eye pressure checked once a year. Increased density of the lens. There is difficulty distinguishing similar colors, and loss of visual receptors in the retina or macula, and decreased acuity. Home programs should have larger print for ease of reading. It means that age relation changes in body composition and function has characteristics which include, for example, when we assume weight decreases, tissue, adipose tissue doubles as expansive functional tissue, body water decreases, plasma albumin decreases around 10% and globulin increases. Membrane permeability possibly increases. Blood flow, cardiac output decreases by 30-40%. Splanchnic and renal flow decrease by more 40%. Renal function, age-related deterioration, and hepatic function, certain function deteriorate. Absorption, main change in drug handling in elderly patient as a challenge. Absorption, passive diffusion unaltered, delayed by decreasing motility. Bioavailability increased by reduced first pass metabolism in liver or gut. Distribution, volume increased or decreased depending on lipophilicity of drug, plasma protein binding changing. Metabolism, phase 1 variable decreased, phase 2 relatively unaffected, and renal excretion rates slowed by decreased glomerular filtration or tubular secretion.